Okay. Is everyone in? Very good.
Yep, people are populating now in from the waiting area.
Okay. I'll give it like a minute,
Yeah, that
maybe.
sounds good.
Yeah.
Welcome, everybody. We're just going to get started in a minute. We're going to let everybody populate over from the waiting room. Thank you for joining us today.
Wonderful. Good afternoon. Welcome. Okay. Well, good afternoon, everyone. Thank you so much for joining us today. My name is Stephanie Funes, a new face to the Drug Free America Foundation. I am the program coordinator. Today's webinar, Food and Mood During the Perinatal Period, the Importance of Maternal Diet for Mother and Child's Mental Health, is supported by the Florida Department of Health and is part of the Drug Free America Foundation's Marijuana and Pregnancy Education Project. Before we get started, here are a few housekeeping items. Please introduce yourselves in the chat. Write any questions that you have in the Q&A box. You can find the Q&A box right in the middle as well, in the bottom of the screen. Any questions that you have, and they will be responded at the end. The webinar will be recorded, and you will receive a link to it along with a PowerPoint presentation and a certificate of attendance. A survey will appear on your screen following the conclusion of the webinar, and we would greatly appreciate it if you could complete it. Alrighty, well, let's get started. Dr. Nathaniel Johnson is in his third year as an assistant professor at the University of Dakota in the Department of Nutrition and Dietetics. He received his doctorate only 2.5 years ago in nutrition and exercise science from North Dakota State University. He has published 16 research papers across a wide range of journals, such as Nutrition and Metabolic Insights, the Journal of Clinical Medicine, Nutrients, Environmental Engineering, and Sensors. He is the vice president of the North Dakota Nutrition Council, a steering member of the North Dakota State Health Plan, and a member of the Phi Beta Kappa, Phi Kappa Phi, and Sigma Chi academic honor societies. He is also the founder and organizer of the UND Disability Affinity Network for Employees, while serving on the Grand Forks Food Security Committee. On a personal note, he loves to exercise and cook for his family, enjoys sports and competitions of all varieties, and has never met a dog that he doesn't like. Let's welcome Dr. Johnson.
Thank you, Stephanie. I appreciate that. That was a great introduction. Yeah, without further ado, I'm Nathaniel or Thany Johnson. I got my PhD from our arch rival of University of North Dakota. That's North Dakota State. And I'm here to talk about food and mood during that period, perinatal period, of course, with an emphasis really on food security and the importance of getting good dietary intake to support both the mother and the kiddo's mental health. So, in order to really kind of establish the argument that I'm going to be presenting here today, this is really the foundation of it. And to clarify my point here, the foundation is the association between poor mental health and substance abuse. So right here we have correlational coefficients. In this particular longitudinal study, they measured mental health before COVID, at a time during COVID, and then another time 6 months after that. And what they found is that mental health at like time one is associated with, well, uh, substance abuse in time two. So just to point that out here on the slide, folks, so people can see. So we have mental health score. This is the pre-COVID score. That's associated with uh, mental health, depression, and stress, and substance abuse at time one. And at pre-COVID, that mental health is also associated with substance abuse at time two. Same thing with mental health at time one. It's also associated with substances used at time point two. So this is longitudinal data to support the notion that mental health does affect substance abuse, particularly in the context here of pregnant women. So the foundation of my argument is if we improve mental health, we're going to improve substance abuse. And we all kind of need to agree on that for this to really work as far as a presentation. Now, I imagine most folks are on board with that. And of course, in addition to that, there is the dual relationship here. Of course, substance abuse can negatively affect mental health status. Mental health status can also affect substance abuse, of course. So the next thing I need to kind of lay out here as far as background information is what exactly is the perinatal period? So there is no scientific consensus as far as the exact dates that the perinatal period starts and ends. So for instance, the World Health Organization defines the perinatal period as a period from 22 weeks gestation to 1 week postpartum. On the other hand, the American Academy of Pediatrics defines it as pregnancy, so conception, so 0 weeks gestation to 4 weeks postpartum. A group of researchers, specifically Garcia and Yim, who did a systematic review, their thought was that pregnancy was from 0 weeks gestation to a whole year postpartum. And so for the sake of this, lecture, we're going to be thinking more of the perinatal period of going up to that 1 year postpartum. And in fact, there might be, some evidence we talk about later that really the perinatal period could arguably extend it across even generations when we're talking about things like epigenetic changes. We'll get there, though, in a moment. Another thing I want to point out here, folks, and we're not going to go through all the different micronutrient needs during pregnancy and lactation. Rather, I just want to highlight different areas where we see increased needs for nutrients during pregnancy and lactation. So in this case, looking at vitamins specifically, there's greater need for vitamin A, thiamine, riboflavin, niacin, B6, it's pyroxidine, folate or B9, vitamin B12, which is cobalamin, and pantothenic acid, which would be vitamin B5. In addition to that, right, there's increased mineral needs as well. And of course, I don't have a slide for this, but there's increased energy needs too. So there are nutrients of concern when it comes to pregnancy and lactation. Specifically for pregnancy, the American College of Obstetricians and Gynecologists highlight folic acid, of course, due to its relationship with things like spina bifida, iron due to its relationship with anemia, calcium and vitamin D for bone health, choline and omega-3 fatty acids for normal mental development, and also the B vitamins and vitamin C being particularly important, or in other words, nutrients of concern for women during pregnancy. Now, this is a nice little figure here from a paper that I like as well. I enjoy that it also includes DHA, which is in particular a subset of omega-3 fatty acids, but one that's important for neurological development of youngsters during gestation. So what about food intake and mental health? Now, to clarify, folks, the information I have presented here is not limited to pregnancy. This is food and mental health more broadly, because there's not a wealth of academic literature about dietary intake and mental health. Now, there's some, of course, but there's not the same amount that we'd see for things like obesity or type 2 diabetes or other conditions like that, right? So in particular, there are a few things that are related to better or worse mental health. So those who have the highest tertile of branch chain amino acids, so we're talking about isoleucine, valine, and leucine, which are amino acids that are markers of dietary protein quality. Increased intake of those related to decreased odds of both depression and anxiety. Another thing would be dietary fiber. 1 gram increase in dietary fiber decreases depression risk by 1%. As far as increasing, mental health issues, those who have the highest intake of saturated fat, particularly 12 carbon length saturated fat, are 40% more likely to have depression. And although this isn't dietary intake itself, those with depression or anxiety tend to prefer saltier foods, which would suggest a link between salt, as in sodium, and depression and anxiety as well. Dietary intake and depression is an area where I do my own research. Now, to clarify, this data is from older adults here in North Dakota. So not pregnant women, of course, but in our own subset of older adults, we found that lean protein intake and fruit intake were inversely associated with depression, whereas lean protein intake, fruit intake, and bean intake were inversely associated with anxiety, whereas processed meat intake, so thinking like, well, a lot of good meats, but a lot of ones that we know are not very good for us. So talking about bacon, salami, prosciutto, uh, packaged sausages, a variety of other things. Processed meats actually increased one's statistically here in our data set odds of having anxiety. So when it comes down to foods and mental health, before we transition here to food security and food agency, we want to be focusing on honestly kind of the basics here. To improve mental health, we want to be choosing lean proteins, things like skim and reduced fat dairy products, lean meats, fish, and soy, because they're high in these branched chain amino acids. Whole fruits and veggies, whether they're frozen or fresh, are going to be a source of fiber and antioxidants, which are also related to improved mental health. And then finally, beans are also sources of fiber and probiotics, which can modulate mental health as well. Things to limit from a dietary standpoint are processed meats, deep fried foods because they're high in saturated fat, desserts and pastries, they tend to be high in saturated fat, low in or high in sugar as well, and also usually low in things like protein and fiber. Salty foods, again, there's association between preferred salt intake and depression and anxiety. And of course, other processed foods like instant noodles, prepackaged foods, and some snack foods are things we should be limiting as far as improving our mental health. Now, fundamentally, I'm really not shaking things up a whole lot here. This is pretty basic information about dietary intake, if you will. If we eat more lean proteins, fresh fruits, fresh veggies, and beans, we tend to be healthier. If we eat more processed foods that are higher in added sugar, higher in saturated fat, higher in salt, we tend to have worse health. Really not a life-changing view here of what we should be eating, but rather we know now that this intake is related to better mental health. So far I've been mostly focused on nutrition, as in the nutrients that make up foods. However, in the context of someone's dietary intake, that's really not how somebody typically behaves as far as how they choose to cook and eat food. So food agency is the ability to actually produce healthy meals. It is the foundation of a healthy dietary intake. It's very challenging, albeit not impossible, of course, to have a good dietary intake or a healthful dietary intake when you're not cooking for yourself or when you're not having family or home cooked meals. In other words, if you're eating out for every meal, it's challenging to not get too much of some nutrients like energy and salt and maybe saturated fat, and perhaps too little of other nutrients, maybe fiber in that case. So food agency is actually determined by 4 different attributes. One of them is nutrition knowledge, which is where I spend most of my time as a nutrition professor. This is the actual nutrient content of food, and people need this information to make healthy food choices. Pretty straightforward. The advantage here is that nutrition knowledge can actually be improved by classes or lessons, and I have information about that later on in this lecture. Culinary skills are actually the skills needed to prepare food. Not to be Captain Obvious here, but if somebody doesn't know how to make a food, they're probably not going to eat that food. And so you'd be surprised on social media in particular, there's lots of videos of people struggling with preparing pretty basic foods, like let's say an avocado, how to prep an avocado to eat, for instance. So if you don't know how to make that food, you're not going to eat it, which definitely impacts your dietary choices. So culinary skills, just like nutrition knowledge, can be improved by cooking classes or lessons. And in fact, oftentimes, nutrition knowledge and culinary skills are taught together in lessons for the public. Environment or equipment is the actual space and tools needed to prepare food. And this is something that we overlook a lot as far as its importance to dietary intake. If somebody doesn't have a refrigerator, or if somebody only has a microwave and not an oven or a range, it's hard for them to make food at home, right? I mean, what can you make without refrigeration? What could you make with, let's say, no range and only a microwave? Well, if you have no refrigeration and only a microwave, your dietary choices are probably pretty limited. Another element to this that has to be stated, albeit I don't have a good solution for folks, is homelessness, right? So people who are unhoused are going to have difficult time getting good dietary intake because they actually lack any sort of environment to actually prepare the food that they need. And finally, folks, the aspect we're really going to be talking about the most here today and the remainder of this lecture is food security, which is the ability to access and afford healthy food. So all four of these attributes are needed really for somebody to have healthy dietary intake. So what is food security and therefore food insecurity? Well, as I mentioned, food security is one's ability to access and afford healthy food. Food insecurity is limited or uncertain ability to access or afford healthy food. There's a few things I want to highlight and call a shout out here before we move on, and that's access, afford, and healthy. There are three components here. One, people need to actually have an ability to get that healthy food. It needs to be at a cost point that's reasonable for their budget, and that grocery store or food provider needs to be accessible within reasonable distance. Food access, as an aside here, folks, just take a little time here, but food access is a big problem here in North Dakota where we have few grocery stores in rural environments, meaning that people, even if they can afford to have healthy food, might not literally actually have that access to healthy food. So when it comes to food security and mental health, the evidence is bad. And that's not a surprise here, folks. People who are food insecure are 44% more likely to have depression and 34% more likely to report stress, albeit in this meta-analysis, food insecurity was not associated with anxiety. And the powerful part about this data here is it's from over 300,000 folks across 19 different studies in 10 different countries. So this really lays a concrete and solid basis between the link of food security and mental health. If people are food insecure, they tend to have worse mental health. And as a reminder here, going back to our first slide to kind of lay the foundation of my argument here, well, we just talked about how food insecurity increases depression and stress. Well, it turns out that depression and stress measured at pre-COVID or time point one is related to things like substance abuse later on. So depression and stress directly affect substance abuse, which is why we care about improving mental health. Again, of course, for the prevention of substance abuse. There's other reasons we want to improve mental health in general too, of course. But for this particular lecture series, that's going to be our emphasis. So food security and mental health during pregnancy, folks, is really bad news. So we see a 10-point difference in those who are food secure, so the highest level of food security, versus severe food insecurity. This is a 10-point difference in perceived mental health on a scale from 0 to 100. So that's a pretty big deal, folks. That's a big difference in mental health. On top of that, we actually see decreased quality of life across all domains assessed in this study, but in fact, physical pain. So food security was related to worse general health, worse physical performance, more role limitations due to both physical and emotional reasons, decreased social performance, worsened perceived mental health, worsened fatigue, and decreased quality of life. Again, this is data in pregnant women that suggests that really food insecurity affects all aspects, not just mental health, but physical health as well. And to support that, food insecurity during pregnancy is related to 53 increased percent odds of obesity in the child, that is specifically, and 64% increased odds of pregnancy complications. And most notably, there is a 388% increase in preeclampsia risk with food insecurity during pregnancy. That's 3.8 times, well, technically 3.88 times as likely. So folks who are food insecure during pregnancy are 3.88 times more likely to have preeclampsia than those who are not food insecure. So beyond the decreased or improved mental health with improving food security, we'd also improve physical health, notably during pregnancy as well. But, and unfortunately, the negative effects of food security or food insecurity in this case actually extend beyond just the pregnancy period, so across the perinatal period into postpartum. This is a quote from a food insecure person in Minneapolis. Of course, the citation's at the bottom. I grew up in the Minneapolis area, so this is close to home for me. But the quote says, "It's depressing because I'm okay with my kids going to sleep with a full stomach, or at least a satisfied stomach that they can go to sleep. But it's uncomfortable for me to wake up and my stomach's touching my back because now I'm upset because there's nothing to eat here." So what Joanna's saying is parents are happy to take sacrifices. I shouldn't say happy, that's a bad way to put it. But parents will naturally sacrifice for their children. So in the case of a lack of food, parents tend to eat less to give more food to their kids. But this isn't without consequence. The mother, in this case, Joanna, is depressed because now she's hungry and she has nothing to eat, even though her kids at least have something. So in this particular project, they found that food insecurity affect parents' reports of depression, which in turn affect parents' report of fair or poor health of their children. In other words, people who are food insecure were more likely to be depressed, more likely to say that their child was in fair or poor health, as opposed to good or excellent health. So it's not an ideal scenario. The same group of authors also reported that food insecurity was negatively associated with positive parenting, meaning that people who are food insecure have less positive parenting practices. Well, positive parenting was associated with better infant feeding practices, and those better infant feeding practices were associated with decreased odds of being overweight. And so food insecurity affect how the parents actually parented, which led to changes in feeding practices, which actually led to phenotypic or outcome-based changes as far as being those children being more likely to be overweight. So food insecurity not only affects mental health during pregnancy, but after pregnancy, which has effects not only on the mother, but on the child as well. So there's some pretty bad statistics about food security or food insecurity, excuse me, in infants and toddlers. And the reason why I have physical statistics here, not mental health statistics, is that, well, it's more difficult, right, to assess mental health in children who are under 3 years of age, right? I have a 1-year-old at home. It's him right now feeding the dog his own food, of course, in the picture. But my kiddo, I don't know how I would do a mental health assessment on him, and he's 15 months. So with these younger kids, those who are 3 years or less, we really only have physical variables as far as what we can find in the literature. So food insecure children are 31% more likely to be hospitalized. They're 17% more likely to have iron deficiency anemia. So that illustrates that poor nutrition, right? Iron deficiency anemia is caused, well, most often by a lack of iron intake. Food insecure children are 61% more likely to be overweight, while counterintuitively being 14% more likely to have stunted growth. So there are physical consequences to food insecurity in children. And actually, these consequences are unfortunately likely carried beyond just one generation. So to lay the framework for that, the Dutch hunger winter was the winter of 1944 to 1945, and Nazi occupied the Netherlands or Holland. The Dutch people were only eating about 800 calories per day. So for perspective, normal dietary intake is 2,000 calories. So 800 calories per day is about 40% of our standard dietary intake. Well, what this group of authors found in a really kind of earth-shattering study way back in 2008 is that there were differences in DNA methylation. This is a marker of epigenetic changes. An epigenetic change is a change to our genetics that doesn't change the code, the sequence of our DNA, but it changes the expression of our DNA. And in this particular research, they found that there were differences in different regions of DNA and their methylation patterns between siblings who experienced the famine and siblings who didn't experience the famine during gestation. So siblings who were essentially conceived during the Dutch hunger winter had different DNA methylation patterns than those conceived during other times. And on top of that, these changes persisted until 2008. And remember, the Dutch hunger winter was back in 1944 to 1945. So that's close to 70 years later. Well, a little bit less than that, more than 60, but less than 70. Well, that particular line of research was followed up with, well, this, of course. So this is other research stemming from the Dutch hunger winter. And what they're comparing is famine exposure and body mass index, so obesity, and famine exposure and triglycerides, which would be one of the markers of dyslipidemia. And what they found is that those siblings who experienced the Dutch hunger winter, where calorie intake was only 40% of what it should be, had increased DNA markers related to both increased BMI or obesity and to increased amounts of triglycerides in their blood, which would be dyslipidemia. So this is real evidence that not only was there a genetic difference between these siblings from the Dutch hunger winter, but there was actually phenotypic or outside or outcome-based changes based on that, period of starvation essentially during the Dutch hunger winter. So this extended that, those DNA changes had real effects on the outcomes of these people. Well, guess what, folks? In 2021, a group of researchers out of Brazil did a similar type of study, but they were looking at food insecurity, a DNA methylation pattern of the NR3C1 gene, and its association with depressive symptoms. Well, they found that food insecurity modulates DNA methylation, which then has an effect on depressive symptoms, and that this modulation or mediation based statistical model was stronger than just food insecurity affecting depressive symptoms alone. So in other words, the Dutch hunger winter showed us that epigenetic changes occur as the result of food and have real outcomes on things like obesity and, well, dyslipidemia. This research shows that food insecurity also affects genes that control things, in this case, related to depressive symptoms. So this means that our dietary intake affects our genes, which then affects our mental health. Well, what about that inheritance or that pass on element? Well, in another pretty groundbreaking study published in 2022, researchers at the University of Wisconsin-Madison fed sheep, which is why I have the picture of the sheep here, the amino acid methionine, which is on the left here. So this is the chemical ball and stick structure of the amino acid methionine. Well, they fed these sheep the amino acid during adolescence. So some sheep got the amino acid, other sheep didn't get that amino acid. And then they tracked changes in DNA methylation patterns over 3 different generations. And the reason why they use this particular amino acid, that's methionine again, is methionine is the reactant that's utilized in methylation reactions for DNA methylation patterns. So again, these researchers are tracking DNA methylation patterns across generations. And well, in the first generation, the DNA methylation pattern differing between those sheep who received the methionine versus those who didn't looks like this. We have regions of hypomethylation in red and hypermethylation in blue. So that's that first generation, that's you. So this is that evidence really from the Dutch hunger winter that our dietary intake affects our genes. Well, let's take a look at our second generation. Well, the second generation pattern here is awfully similar to the first generation pattern, suggesting that that change, just that methionine fed to that first generation, had notable and trackable effects on DNA methylation all the way out to the second generation. Well, I imagine that folks out there in the audience know where this one's going. The third element down here is the third generation, where we see essentially a similar DNA methylation pattern. So this is evidence, albeit it is from an animal model, that DNA changes in one generation affect at least 3 generations down. And I've talked to this group of authors, and on a level of I guess just person to person, they tell me they also have data that goes down to the 5th generation that supports this, that of course they're looking to publish in a more formal means. Nonetheless, the point I want to make here is genetic changes related to dietary intake are passed down to at least the second generation. That'd be someone's grandchildren. So we're talking about food insecurity during pregnancy. We're really not talking about just that mother and child, but that child's child and that child's child's child's. And honestly, all the way down, probably the rest of, well, children that those people might end up having, right? So nutritional epigenetics really states that dietary intake not only affects the mental and physical health of people today, but also that of future generations. Well, would there be some data to support that? Well, indeed, there is. When we talk about food insecurity and mental health in children and adolescents, well, children and adolescents who have low food security, so they're somewhat food insecure, they're 26 and 33% more likely to have a mental disorder with impairment. So the children, 26%, the adolescents, 33%. That's bad, that's concerning, but it gets really bad when we talk about very low food security. So children and adolescents who are very much lacking food are 255% and 344% more likely to have a mental disorder with severe, not just impairment, but severe impairment. And to clarify, 255% is 2.55 times as likely, 344% is 3.44 times as likely. And of course, there is the more acute effects of food insecurity on, children's mental health. But as I just went over, there's also the generational effects of food insecurity on mental health as well. So food insecurity has drastic implications, in particular for children and adolescents' mental health. Nutritional epigenetics is an area of research I'm also involved in. I have a couple articles published here. If you're curious, this article is actually written for the lay audience. It's something you could share with your patients or other providers. It's not written at the level of, let's say, like an academic journal article. So I would refer people to that if you get a chance to share it with people. It's published in a couple different places, in fact. But to move on from that and to stop talking about myself, let's talk about a little bit of our case study here, Sarah. So I'm going to read the case study out loud, partially so that way I know we're committing enough time to it for all of us. So pardon me there. But Sarah, 28, had been working as a retail associate to support herself financially during her first pregnancy. However, as her pregnancy progressed, she was forced to reduce her hours due to fatigue and discomfort. Her family lives several states away, and while they offer emotional support, they're unable to provide any more assistance. Sarah's partner, while also supportive, is struggling to maintain a steady job due to economic downturns in the area. The pressure for providing for their growing family among rising costs has taken a toll on their relationship, leading to increased tension and conflict. On top of that, the family is having trouble affording food and often feels too busy to cook. The weight of her circumstances are starting to feel overwhelming, and Sarah reports feelings of helplessness, fatigue, and sadness. So first of all, folks, if you can and you have the time, why don't you put up some ideas in the chat? What would be your first step here with Sarah? I mean, I can think of some things right away. I can think of some things that I would do as a nutrition professional right away. Like wait just about a minute here. And don't be too formal, folks. You can just toss pretty informal things up in the chat. I have some fun with it. Is the chat enabled? Actually, I don't know if the chat is enabled. I apologize if it's not.
It is enabled.
Oh, I see it now. Okay, all right. I got all sorts of chats. Awesome.
We have housing support, refer to
food stamps, educator on different outlets in the city that provide free food. Great idea. Yeah, I think that's a good start, and we'll honestly, we'll move on from there. I had a lot of similar thoughts of other people here. So my first step would be, before screening for, I shouldn't say before, obviously we should be screening for mental health. That's typically right a part of standard clinical practice to do those mental health screeners, at least, if not the full questionnaire. But one thing that's not as typical is screening and assessing all patients for food insecurity. My recommendation to do this, just so we're all on the same page, is the USDA 6-item short form food security survey module. These 6 questions and scoring are listed here, folks, as is the link right to download the full questionnaire. The other option, right, is to use a single item from this questionnaire as a screener, and then those who answer yes complete the remaining 5 questions. But as you can see, the questions are food that I/we bought didn't last, and we didn't have money to get more in the last 12 months. We couldn't afford to eat balanced meals in the last 12 months. In the last 12 months, did you or other adults skip a meal? How often did you skip a meal? Did you eat less because there wasn't enough money for food? Were you hungry because there wasn't enough money for food? So my first step, right, like people were saying, screen and assess all patients for food insecurity. We also should be determining if patients are eligible for WIC or SNAP benefits or other more local benefits if they're available for you, right? So that was a really good thought. I saw that in the chat as well. One of the things that can help if you have a local partnership that's willing to is one of the other problems during the perinatal period is actually food access. So food access, I mean specifically getting the food that somebody needs. If you're a single mother and you're at home with a baby and you have limited means, getting to the grocery store, getting out there to actually get that food amongst the craziness can be very challenging. So expanding programs like Meals on Wheels, which is meant for seniors, to cover women in the perinatal period is something that can be successful in some communities, depending on funding and the interest, right, of people wanting to support new mothers. Alternatively, some communities start their own program to support meal delivery for people in the perinatal period. One of the other things that we can do at our food systems is create food banks that provide food for people or an opportunity for it at the actual medical appointment. So though, of course, there are food pantries or banks in your local community, I'm sure one-stop shopping is great, particularly like if you're taking the bus or other types of public transport. I mean, getting from one place to another is easier said than done. Add on, I don't know, what, 30, 40 pounds of pregnancy weight, and then that gets even worse, right? So having that food actually available at the hospital or the clinic is a great way to make sure people are getting some dietary intake. On that note, some really, I would say, ambitious is the word I'm going to use. Ambitious health facilities have actually started growing their own food. So some health facilities, like in town here, they're building a little greenhouse, and this allows these areas to produce food that then can be given out to folks there. There are actually psychological benefits to gardening as well, or working on food. And so that's another benefit to that approach. But the final one is probably the most realistic area for folks here to start as clinicians, and that's partnering with local nonprofits and charitable organizations. Folks, knowing where people can get that access to free food or housing support or childcare support is critically important for providing people during the perinatal period the support that they need for good dietary intake and good mental health. So we talked a lot about food security. I'm going to finish up our conversation today talking about nutrition knowledge and culinary skills. These are areas we're going to be spending less time because they're perhaps a little bit more obvious. I do want to have a little shout out to environment/equipment because, well, I'm not going to be spending as much time on that, but I don't want to downplay that. Providers can help with an environment or equipment by actually providing equipment. So the classic example that someone could use is if you're going to provide canned goods, well, how about providing a can opener? Anyway, so we're going to talk about nutrition knowledge and culinary skills. This is data from a nutrition education program for pregnant women with the goal of increasing iron intake and improving hemoglobin status. The actual intervention was effective. So teaching women during the perinatal period, how to eat more iron actually improve their iron status. So I'm not trying to rework the wheel here, folks. We know this is kind of an obvious point, but nutrition education performed correctly is effective. On top of that, interventions intended to empower women, specifically during the perinatal period, are associated with lower levels of depression and lower chances of premature birth. So these cooking and nutrition classes that could be given for women during pregnancy actually also offer an opportunity for empowerment. So we can improve massively things like nutrition knowledge and culinary skills by simply just offering classes. The classes are effective and they also offer these opportunities to empower women. So when it comes down to it, improving food agency, here are some ideas that we can do to improve food agency. We can offer classes to improve culinary skills and nutrition knowledge while empowering women during the perinatal period. As clinicians, we can partner with government agencies and nonprofits to find solutions for housing or equipment. We can screen folks for food security, and we can refer people to WIC and SNAP eligibility. I would recommend screening everyone for food security, because even if people are not WIC or SNAP eligible, they still could benefit from going to a local food pantry, and that food security coupled with an understanding conversation with their provider can be the impetus for someone to actually take advantage of one of those resources. And then finally, the last thing we could do as clinicians to actually improve food agency would be to increase opportunities to access healthy food. So whether that's providing food at the appointments themselves, sending a box to people at their homes, or something else, access to that healthy food is important as well. And that's it, folks. Thanks for your time. I have a couple pages of references here for those who want to see it, of course. And I'm more than happy to answer your questions. That's my son. He's got a question to ask too, of course, that face. And so any questions you might have, I'm more than happy to answer them.
Yes, if anyone has any questions, please do add them on the Q&A. I do want to say thank you, Dr. Johnson, for this insightful discussion, highlighting how maternal nutrition plays a vital role in supporting both mental health and overall well-being during this critical time for mothers and their babies. It's very important. I actually, before I move on, if anybody has posted any questions, I had one of my own. I'm sorry if I missed this, but are any of those epigenetic changes reversible? I know you mentioned that they were visible from the study that was from the 40s all the way to the early 2000s. I was just wondering if once you are able to, or reach kind of like a access and stable access to food, are those changes reversible somewhat?
We don't know. That's actually the scary element there. I'm working with that same research group that published the animal study. We're trying to do a reverse study where essentially we're going to have a bad diet, if you will, in one generation, and then in the next generation we'll have a healthy diet, and we'll see if we can reverse those epigenetic changes. But I don't know, and that's the scary part with it. They might not be all that reversible, depending on what they are. It might vary depending on the change and the location of the change. We don't know.
Thank you. So I don't see any questions on the chat. I had seen one about the slides. Yes, they will be available. Well, I guess that calls for an early end. Oh, someone said, thank you, Dr. Johnson. Food insecurity does not let the brain develop normally. And yes, it can go for generations unless someone's generation starts to change. That was a little note from Doris Smith.
Why we got to start making those changes today.
That is true. That is very true. Well, thank you so much, everyone. Again, there'll be a survey at the end. If you guys could please complete that, that would be great. I appreciate it. Thank you so much, Dr. Johnson, for your time. And I hope everyone have a great day.
Thanks, everybody. Thank you for being here. I appreciate it.